Thank you very much for a very interesting talk. The next speaker is Professor Giovanni Frisoni. Professor Frisoni graduated in medicine in 1986 at the University of Brescia and specialized in neurology in 1990 at the University of Parma in Italy. He is currently Deputy Scientific Director of the Scientific Institute for Research and Care and Director of the Laboratory of Neuroimaging and Telemedicine at the Istituto di Ricovero e Cura Carattere Scientifico Fate Bene Fratelli. He is also past chair of the Neuroimaging Professional Interest Association of Alzheimer Association International Society to Advance Alzheimer's Research and Treatment, steering committee member of the European Alzheimer Disease Consortium and scientific coordinator of the Northern Italian branch of the Associazione Fate Bene Fratelli per la Ricerca. Professor Frisoni is the author of more than 300 publications and is currently the imaging section editor of the journal Neurobiology of Aging. He has held several clinical positions, the most recent being the head of psychogeriatric ward at the Istituto di Ricovero e Cura Carattere Scientifico Fate Bene Fratelli. Thank you, Professor.
Thank you, Charles, and thank you, the Alzheimer's Europe, for inviting me. I don't know whether you will leave this room richer in knowledge than you arrived. I, as a speaker, have certainly learned that the bios that I sent should be way, way shorter. And I will try to make the same psychomotor exercise that the previous speaker did. And I will address, and let's do something more daring. I will not have the ambition to cover, so how is this going to work? No, this is not going to work. No, it's... Okay, 3. Wow. So I don't have the ambition to touch the all EU-funded and international research. I will touch a few projects that I believe are giving us some insight about the topics that have been touched so far. So. I will start with a few comments, very few of them, on the pathophysiological model that we use for Alzheimer's. Most of what I was planning to say has been said already, so this should make you happier. I will pass on to the second point will be to test the model in clinical practice. I believe this is critical. I suspect that to patients and family relatives, this is a critical issue. Whether what the ideas that scientists have in their mind really work in clinical practice. And I will then touch on another point which looks more technical, but it's absolutely central to the use in clinical practice, and meaning the translation of biomarkers in practice. And I will try and persuade you that how you measure a marker is at least as relevant as what marker you use. And finally, I will try and give a few food for thought for the future. Now, you heard about this before. So let me go fast just to highlight that this is the change in the markers that we believe, based on a number of patchy observations, the change of markers that we believe takes place in the brain of patients moving from the asymptomatic phase to the MCI stage to the dementia stage. First we have amyloid that increases, then we have functional changes, glucose use and synaptic markers of synaptic dysfunction, and then tissue loss, atrophy. And we have markers, we have imaging markers for each of these phenomena. We have markers for amyloidosis, as you heard, but we imaging markers for amyloidosis, but we also have CSF markers for amyloidosis. We have markers for glucose metabolism and synaptic dysfunction, fMRI and FDG PET, and we have markers for tissue loss, volumetric MRI, hippocampal atrophy, medial temporal atrophy, global brain atrophy. Now, you heard already that we are now able to clear the brain from amyloid. And these are treated patients, amyloid imaging at screening and after treatment. An untreated patient, amyloid increases. So with imaging, we can visualize that really amyloid is cleared from the brain with the drugs that the previous speaker has illustrated. Okay, the issue here is, of course, treating earlier. This has been said already. And these are the data from Randy Bateman from the study on families that was presented. I will use it here to just to support the notion that the progression of the biomarkers from amyloid biomarkers to glucose metabolism to atrophy holds not only in the sporadic forms, but also and foremost in the familial forms. And this is critical because the reason why we are working on the amyloid hypothesis, the evidence comes mainly from these people here, from those with genetic disease. The largest amount of evidence comes from these guys. So the model works in families, and we believe that it should work also in sporadic Alzheimer's. But is this the case? Question mark. The whole model is the one where Bruno Dubois and other people from the other scientists mainly from the US have developed new criteria. So if we move on to the clinical setting now, okay, this is the general picture. Let's move on to the clinical setting. If we go to the clinical setting, one might do a number of predictions about patients with MCI. From Bruno, we heard that MCI does not necessarily mean Alzheimer's. MCI means memory problems. An MCI patient can have Alzheimer's, but he or she can have something else, may be iatrogenesis, memory problem due to drug, or his or her memory can be poor to start with. You can have poor memory without having Alzheimer's, can't you? I forget a lot of things as well, and I hope I don't have Alzheimer's. So the MCI patients that we see in clinical practice, in theory, might fall into 4 baskets. The first basket is the one of patients with no amyloidosis, normal glucose metabolism, normal, no brain atrophy. These are the patients who have poor memory to start with. And they don't have Alzheimer's, they will not develop dementia if the model works. The second are patients with brain amyloidosis, but for not yet cortical hypometabolism, not yet hippocampal atrophy, or so mild, such mild cortical metabolism and atrophy that our techniques are not sensitive enough to pick them. The third Now, I'm sure you understand which the others are already. The third is amyloidosis, cortical hypometabolism, no hippocampal atrophy, and the fourth one is all three of them. So, if the model works, the majority of patients, sorry, this was not supposed to come now, the majority of patients with MCI should fall into one of these four baskets. Is this the case? To test this, we pooled a number of MCI patients seen in 3 memory clinics in our place, in Amsterdam, and in Stockholm, who were MCI patients who had been studied with all 3 markers, MR, high-resolution MR scan, FDG PET, and CSF. And these are not very many in the world. Believe me, there's a handful of them, because most of the memory clinics take MR plus CSF. Many take only MR. Some even take only just a CT scan, but that's another cup of tea. Most take most of the academic memory clinics take MR plus FDG PET, MR plus CSF. Few of them MR plus amyloid imaging, but all 3 markers of amyloidosis, glucose metabolism, and atrophy, there's very few of them which do. And for a number of local reasons, not because we are the best, the brightest, but because we are luckier than others, we had the opportunity to study a few MCI patients who had all of these. And some of these MCI patients had a decrease in the MMSE over time. On the y-axis, you have age, 50 to 80. And a few others did not progress, remained stable with the MMSE, or even increased. So if you look at, and another factor that contributed to make this study possible was that the markers were taken with a similar method, not really strictly harmonized, but with similar methods in the 3 memory clinics, for a number of reasons that I will not go over. So overall, we had 29 MCI patients who progressed, and 44 who did not progress over about 2.5 years of follow-up, which is not a very long follow-up, but it's not bad, it's something. MMSE was about 27, which is okay, and the age was relatively young, 65. They're oldish, but not that old. They're not very old. 65, as I approach that age, does not look really very old. Okay, so first prediction, as I said, the first prediction is that most of the MCI or MCI patients should fall into these 4 baskets. Those who do not, either it's possible, of course, that some do not fall into the 4 baskets. People might have cortical hypometabolism and or atrophy, but no amyloidosis, and these are non-Alzheimer's diseases, non-Alzheimer's causes of cognitive deterioration. Or our biomarkers may have failed because they're not perfect. Even measuring your blood test can give false results sometimes. So this is what we found, that 3/4 of our patients fell into one of these 4 baskets. So fine. And this is in line with what others have found, actually. Only 1/4 do not fit the model. So overall, the model fits. But the other prediction is that progression to dementia should be more frequent with increasing marker positivity. Those with all markers negative should not progress to dementia. Those with all markers positive should always, in theory, progress to dementia. And everyone in between should be intermediate. And this is exactly what we found. no marker positive. Only 1 of 22 developed dementia after 2.5 years. 10 out of 10 developed dementia of those with all markers positive. So the trend is very clear, but what's more important than the trend is that prediction here is 100%, prediction here is almost 0%. And this is not affected by age. This trend is true in young and old, high and low MMSE. Young and old means above 65 and below 65. APOE4 carriers and non-carriers, and of course also in all 3 centers. The third progression is, the third prediction is also that those with markers, all markers positive, have a more severe disease. So dementia, those who develop dementia should develop dementia earlier than the others. And this is precisely what happens. Those who develop dementia, if they are all positive, have a delay of slightly longer, more than 1 year, while those who are only beta positive have more than 2 years of delay. So this is with this data set, we were also able to make a head-to-head comparison, and Bruno, you have seen this too long already. We have been able to make a comparison of the two sets of diagnostic criteria, the European and the Americans, so to say. And I will not discuss that. I showed that only to tickle the curiosity of my friend Bruno Dubois. So the conclusions of, but what I meant by this joke is that if we were able, these were only relatively few patients, but if we were able to have these data on a larger data set, on not only 3 memory clinics, but 30 memory clinics, 100 memory clinics, we would be able to figure out the algorithm that Bruno was referring to that would be most efficient and effective to diagnose the disease at an earlier stage. And my chairman is...
You have around 2 minutes to conclude.
Oh, a long time. So, the conclusion number 1, conclusion number 2, you can read them yourselves. And there's a number of open issues. The open issue that I would like to address, the only one, is the fact that one of the questions that left open is which is the most accurate individual marker. If you have only one shot, would you do MR, would you do CSF, or would you do FDG PET? The answer is not obvious. With this multi-center study, we made a meta-analysis of 130 independent studies addressing the predictive value of these markers for the predictive value to development of dementia in MCI. And to make a long story short, I will show you only this slide. This is a slide that compares the positive likelihood ratio. Likelihood ratio means the probability that a patient has the disease if he or she tests positive on a marker. This is a comparison of the positive likelihood ratio of amyloid PET, FDG PET, SPET, MRI, measured in a different way. FDG PET can be, cortical hypometabolism can be measured in 4 different ways. Medial temporal atrophy can also be measured in 4 different ways. If you look at the markers, overall, the likelihood ratio goes between 10 and slightly below 5 for MRI, FDG-PET, and so on, between 10 and 5. But within FDG-PET, which has a likelihood ratio, a good likelihood ratio of 8, depending on how you read FDG-PET, the likelihood ratio varies between 2, which is bad, which is lousy, and 12, which is great. So this means that if someone is diagnosed with with FDG-PET or with MR, it doesn't tell you anything. It depends on how FDG-PET is read. It depends on how MRI is read. So the consequence here is that it's absolutely critical to harmonize how these markers are collected in the very same way as we now have standardized operational procedures for any blood marker, for any regular marker that is used in clinical practice for diagnosis. So we should do the same here. If you measure your serum glucose in Vienna or in Sicily, you will have the same assays, right? The same results. So it should be the same in our world, in the world of Alzheimer's. There's an effort, an international effort, and I like to leave you with this message to show that there's a huge synergy. There's a great synergy between Europe and the US towards progressing to having science progress in this side. And this is the I want to leave you with a movie with a few messages and a movie and a few thanks to a number of people and my patients, who are not my patients, of course, but they are critical, and a movie of a work on the standardization, on the harmonization of hippocampal volumetry, so that the aim is to have hippocampal volume measured in the very same way all over the world, and we should do that for all the biomarkers, and if we are able to do that, science on Alzheimer's and clinical application of what we know about Alzheimer's is going to improve dramatically in the next few years. And I thank you for your attention.